clinical research category for an article on the using HCV NAT positive donors in transplant recipients, which has actually been rolled over into a policy in this province. So a very amazing example of from publication to policy change, which is quite impressive. So Matt's going to talk today about some of the work he's been doing on the economics of kidney transplant in the elderly.
Thanks for the introduction, and thanks for the opportunity to talk to you guys today. I appreciate this venue as kind of a way to showcase what I've been working on for the past couple of years and talk a little bit about the economics of kidney transplant in the elderly. This is a topic that has the potential to be a bit dry just because the economic end of things, so I'll try to keep it as lively as possible. But also, just in general, this is something that we're encountering more and more as we move forward, as our elderly population is making up more and more of who we're seeing for both pre-transplant evaluation, but also in our dialysis units. So we'll get started. I don't really have any financial disclosures of significance or any other disclosures to really impact this talk. There are some objectives, so we'll talk about the economic evaluation of kidney transplant in the elderly and the considerations that go into that. We'll discuss some of the gaps in our understanding and some future directions for research and potential policy implications of those gaps. And then along the way, we'll review some core health economic concepts just to provide some background for what I'm presenting. So the first thing is, what is health economics? A lot of people have different ideas of what this means, and there's multiple different definitions. But if you look on Google what economics means, they consider it the branch of knowledge concerned with the production, consumption, and transfer of wealth. Well, that's not really, if we're talking about health, you just can't add health in front of that. That doesn't really work. So when we're talking about health economics, it's really a balancing act between three different factors. And the first one is that the resources that we have available to us, particularly in a public healthcare system, are scarce. So in kidney transplant in particular, we have two scarce resources that we have to consider. The first is obviously the kidney, which is an exceptionally scarce resource. The demand far out exceeds the supply. And then the second resource is obviously money. So there's always, in a public healthcare system in particular, but also in any healthcare system, there is a limited amount of money that is available. And any decision that we make about care, whether we increase funding in one area, comes at the cost of funding something else. And in BC, whether, we often think, we can just increase our healthcare budget, but that comes at the cost of taking money away from other things, whether that be education, infrastructure, and those sorts of things that come from the same budget. So that's the one consideration. The other consideration is the welfare of various groups. So whether this is your individual patient in front of you, or whether this is society as a whole, that's one of the key considerations when we're looking at the health economics of any kind of, whether it's a health problem or a health population. We have to try to optimize the welfare of our population, and that's what we're trying to do with health economic evaluations, is provide the information that gives decision makers what they need to really make the correct decision for optimizing welfare, and also, in the end, providing choices for both decision makers and for patients. And so figuring out what influences those choices and what and how patients and healthcare decision makers perceive those choices. So this is what it's really about. It's the interplay between these three things. And you'll see multiple definitions, but this is kind of what I use as a contextual framework for health economics. This is not news to anyone in the room. So there's about 38,000 individuals with end-stage kidney disease in Canada. This is according to the 2017 CORE data report. And the Canadian Agency for Drugs and Technologies in Healthcare just released their report of the expected costs of dialysis therapy. It ranges between 23,000 and 83,000 Canadian dollars. This depends on your modality, obviously peritoneal dialysis being much less expensive than hemodialysis. And this is not the cost for other resources that go into the care of end-stage kidney disease patients. This is just the cost of the dialysis therapy on an annual basis alone. So that's a substantial number. And when we look at the last paper that really looked at the total economic impact of end-stage kidney disease in Canada, it estimated that $1.9 billion of healthcare spending in Canada were attributable directly to end-stage kidney disease. This was in 2007, and since then that number has, if not gone up by 50%, almost doubled. So we know that we're spending a disproportionate amount of our healthcare dollars on a fairly small number of patients. And so it's in our best interest as providers, but also as taxpayers, to understand how we're spending the money and how to spend it in the best way possible. This is an older paper, but it still conveys the information that is important, in that our population has shifted, and it's not necessarily composed of younger patients with kidney disease. It's mostly older patients, and we know this from what we've seen in our clinics and dialysis units and transplant clinics, is that older patients are making up more and more of the proportion of our patients with end-stage kidney disease. And when we look at, this is again from the last core report, I'm not going to go through the whole thing, but if you look at the total numbers of patients, we're looking at 3,700 patients between the ages of 65 and 75 with end-stage kidney disease with a transplant, and over 1,000 patients over the age of 75. And overall, we've got about 15,000 patients with end-stage kidney disease who are over the age of 65. So this is a staggering number, really, when you think about the costs of the therapy and also the comorbid illnesses that these patients have. So I'm going to go through the economic appraisal of a transplant in the elderly, talking about it in kind of the pieces that go into a cost-effectiveness analysis. So the first is, what's the survival benefit of transplant in the elderly? Second, what is the cost of kidney transplant in the elderly? And then what is the utility, which is an economic term for really what's the quality of life like post-transplant? And then finally, the cost-effectiveness of transplant in the elderly. So when I was thinking about the survival benefit in the elderly, there's a lot of things that go into it. The first is the age. So we know that a 65-year-old and a 70-year-old and a 75-year-old are not all going to be the same. So how does the age within what we consider the elderly, the over 65-year-olds, impact the survival benefit of transplant in the elderly? The second big question is, how do comorbidities impact the survival benefit of transplant in the elderly? Because we know that our older population, they certainly have more comorbid diseases. And then finally, how does donor quality impact the survival benefit of transplantation? So whether you get a living donor versus a deceased donor, and whether this deceased donor is a donor from a more marginal donor or whether they're from a young, healthy individual. So I think almost everyone in the room at some point in the past 20 years has seen this slide. But it's an important one because it's the first seminal paper that demonstrated a survival benefit with transplantation. And what this cohort did was they compared waitlisted patients, so patients waiting for a kidney transplant, to patients who ended up receiving a kidney transplant, and demonstrated that around 106 days was the time to equal risk, so adjusting for that kind of early post-transplant mortality risk that we see with the surgery and complications thereof. And then around 244 days, their survival was equal to those on the wait list, and beyond that, they received a survival benefit. The problem with this analysis is that they conveniently excluded all patients over the age of 70. And the group that was between the age of 60 and 70, there was only really a handful relative to the rest of the population. So this doesn't reflect the survival benefit of patients in the elderly. It was convenient for them because a few years later they went on to publish a survival analysis of people over the age of 70. So I'm not sure whether that was planned for publication or whether that was just the way they decided to do it. But interestingly, in this cohort over the age of 70, they found very similar results. So the time to equal risk was 125 days. The time to equal survival was quite a bit longer, so just over between 1.5 and 2 years. But they still showed that there was a substantial survival benefit associated with transplantation in the elderly. That being said, the expected improvement in survival, although it's substantial, you're going from, at 4 years, their expected survival with the transplant was 66%, and in dialysis was 51%. So that's not a huge difference, or certainly not as big a difference as we see in the general population for a survival benefit with transplantation. There are some issues with this analysis in that it's not adjusting for the quality or the type of donor that was received, and it was only adjusting for a couple of other variables. In particular, they didn't really look at the comorbid illnesses of the patients in detail. So it's closer to an unadjusted analysis, but it still is a good place to start. The next slide, again, we've seen this many times. It's some local work from John Gill and at the time, Karen Rose. And this basically was a study of patients over the age of 65, again, comparing patients who are on the wait list to patients who received a transplant, stratifying it by the type of donor they got, so living donor, standard criteria donor, or expanded criteria donor, so someone with comorbid, if the donor had diabetes or a history of cerebrovascular accident. And then also stratifying by the risk from a cardiovascular perspective. So they defined low risk as no diabetes, no history of MI, no history of heart failure. Intermediate risk was one of those features. And then high risk was 2 or more. And what they showed was that in the low-risk category and intermediate risk category, you still got a significant survival benefit that was very similar to what was seen in the previous analysis. But in the high-risk category, particularly with the expanded criteria donor kidneys, it took a long time to get to a survival benefit. So that's this curve right here on the right. And the time to equal survival was 554 days, which is quite a substantial increase compared to what was previously seen in other analyses. So when we're talking to our patients who are elderly, who have comorbid diseases, and who are most likely going to be getting a higher-risk donor kidney because of the way allocation currently works, this is the number we often are talking to them about, is that they're expected to wait. You know, if they survived over 500 days after their transplant, they might see a survival benefit. But otherwise, they may not see a survival benefit from transplant. So this is work that we just presented this past month at the Cutting Edge of Transplant conference, and it's very similar analysis, just essentially with updated data and also stratifying by the donor quality in a bit more refined detail. So for those of you that aren't familiar with the Kidney Donor Profile Index, this is basically a score from 0 to 100, and they use the risk of graft failure from the previous year's transplants, and they assign the donor a score from 0 to 100, 100 being the worst outcomes from the previous years. It's not entirely intuitive, and then 0 being the best. So 0 to 80 would approximate what we would consider a standard criteria donor kidney, and anything over 80 would be essentially the equivalent of an expanded criteria donor. But within that, we know that the kidneys that often are getting discarded are in this 91 to 100% group. So if we look at kidneys that people say, well, that kidney was too marginal to use, that's really the 91 to 100% KDPI, and that's why we stratified this way. So this analysis compares people that are on the wait list, again, to people who received a transplant, stratified by the donor. So living donors, KDPI of 0 to 80, which would be approximately our standard criteria donors, and then KDPI 81 to 90, and then 91 to 100. And this is just the unadjusted Kaplan-Meier curve, but it really doesn't change substantially with the adjusted analysis. What we can see is with a living donor in patients over the age of 65, you see a substantial survival benefit with transplantation. So we're seeing, median survival approaching 9 years, which for someone at the age of 65 is actually not a bad outcome. Compared to outcomes on dialysis, which we know in our elderly population are not great. So when we start people on dialysis who are older, we often are not expecting them to have a great survival. And this is, again, selecting people that are already, at some point, someone deemed was eligible for transplantation. Interestingly, there is still a survival benefit with the KDPI 91 to 100%. So some may argue that this is a justification for not discarding those kidneys, and we can see that there is some benefit. But the benefit is not as much as we would expect from potentially better quality kidney. So we're seeing maybe 1 or 1.5 years of additional median survival. And then I'll just draw your attention to this top corner of the graph, which is a bit busy. But when we're looking at how the survival curve plays out in the first couple of years, what we see is that living donors basically, with a living donor transplant, you get an immediate survival benefit. Once you survive the surgery, you get an immediate survival benefit. But then when you look at a recipient of a deceased donor, so this would be a standard criteria kidney, your time to equal risk would be 197 days. And then with these high KDPI kidneys, again, it's very similar to what John found, is that it's getting closer to 500 days, so 475 days. In the adjusted analysis, these numbers are very similar. So again, this is similar to what's been shown before, but just demonstrating that early on post-transplant, there is a fairly high risk of mortality. This graph shows the hazard ratio over time post-transplant, again, stratified in those categories of risk of the donor. And this is adjusting for comorbidities, time on dialysis, modality of dialysis, and history of MI, history of heart failure, and history of hospitalization before going on the wait list. And what you can see is that, again, with the high KDPI kidneys, you still get a survival benefit, but it's substantially less than what you get with a living donor transplant. This is the question that we often get asked about: where is that? How old is too old, essentially? This is a great question, and this doesn't actually give us an answer. So the problem is that as patients get older, their risk with transplantation goes up, so their risk of mortality increases, but so does their risk on dialysis. So when we're looking at different age categories, so between the 65 to 70-year-olds, 71 to 75-year-olds, and greater than 75-year-olds, their survival benefit from a living donor transplant is essentially the same in all age categories, and the survival benefit from a KDPI 90 to 100 kidney is essentially the same in all age categories. But that's not to say that they don't have a higher risk of death when they get older. It's just saying that the relative benefit they receive from transplantation is still preserved in those age categories. Interestingly, we looked at different, using the same data set. This is, again, age greater than 65 data set. We looked at the impact of comorbidities on the survival benefit of transplantation in the elderly. And when we look at it, it's really driven by diabetes is the main factor that impacts your survival benefit. So a diabetic who receives a higher KDPI kidney, meaning a somewhat lower quality kidney, their survival benefit is even less. They still receive, again, a survival benefit in the long term, but because they have a high risk of complications perioperatively, high risk of mortality early on, a diabetic who's older, who is also going to receive a high KDPI kidney, is really going to not see the same survival benefit as somebody who's getting a living donor transplant. So that's, again, another consideration when we're talking to people about what they're going to expect from transplantation. So just to kind of summarize that, transplantation in general does provide a mortality benefit compared to dialysis, and that occurs regardless of the type of donor, but obviously living donor transplant recipients have the best outcomes. And the survival benefit that we see is partially due to the poor outcomes that are experienced on dialysis in the elderly. And there's one kind of point I'd like to make in that these are very selected individuals. So when we're talking about even getting onto the wait list as a 75-year-old patient, there's a lot of things that go into that decision that aren't measured. Particularly, frailty is not well measured or well captured in any database that's looked at this issue. And whether that frailty is assessed with an eyeball test or with a formal frailty score, we know that frail patients do poorly and are often, they'll either be pseudo-listed, as in they're put on the list, but they're put on hold because of indefinite investigations that will continue for the rest of their life, or they're listed and then removed fairly quickly because they're no longer eligible, or they're never listed because of that kind of frailty assessment. So that's not well captured in any of these analyses and is certainly a drawback to our understanding. So what about cost? And sometimes in life, all you really need is a lot of money. Well, That is true of the care of kidney patients, but is true in transplant as well, and sometimes all we need is a lot of kidneys. So again, this is a similar set of questions. What's the impact of age on transplantation in the elderly? What's the impact of comorbidities on the cost of transplant? And how does donor quality impact the cost of transplant? So when we're talking about cost, as I go through what's available in the data and what we've looked at recently, is that it's important to understand the perspective of the cost estimate. So this, broadly speaking, there's two main perspectives that are presented. One is the healthcare payer or provider perspective, meaning these are just the medical costs that are incurred to the healthcare system. And the other perspective is a societal perspective. So this includes not only those healthcare costs, but also the indirect costs that are experienced by the patient. So loss of income because they can no longer work full time, the to and from dialysis transportation costs. Those are kind of key examples of indirect costs that usually wouldn't be measured. For the most part, no one's really looked at this in great detail. There's a handful of papers that do look at the societal perspective, but for the most part, it's the healthcare payer perspective, because that's what we as taxpayers often are caring the most about. And within that, you can kind of see three different general outlines for it. So whether it's the healthcare system as a whole, which is often what you see in Canadian papers, or a third-party payer, which is what you usually see when you're looking at American data. So whether that's Medicare or a private insurance company. And then finally, which is fairly uncommon, is the hospital perspective. So these are the actual costs on the ground of providing care. And in general, in Canada, we can't provide these costs because it's all under one kind of hospital budget. So trying to tease out what the individual cost of, for example, a CT scan, when you've got hundreds of CT scans all rolled into one budget, it's very difficult to provide an accurate number. And in the U.S., where they keep track of everything down to the dime, this is proprietary information, so they don't generally release that. So for the most part, we're looking at third-party payer information when we're talking about the costs. Every few years, the OPTN in the U.S., which is responsible for kind of managing the transplant activity in the U.S., publishes an economic report of what it costs to do transplant in the U.S. This report is not great for many reasons, but essentially what they did for this report is they looked at all the costs in 2014 that were billed to Medicare as a third-party payer, and they just estimated, okay, how many patients were in their first year of transplant, how many patients were in their second year of transplant, and then they looked at the total cost for everyone that was in their first year of transplant, and basically it's simple division to get those estimates. But what we can see is that the average cost for a first-year transplant patient was $82,000, which is fairly similar to what the estimates would be for a year of hemodialysis therapy, and it's slightly higher in the age greater than 65 category. In the second year of transplant, you can see that the cost is substantially less, so approaching more similar to what we'd see for a year of peritoneal dialysis therapy. The cost was $26,000 for most recipients, and then it goes up to almost $28,000 for elderly patients. There's a couple of problems, and these numbers are generally underestimates, because unless you got your transplant on January 1st, 2014, and had an entire year of Medicare billings and payments, then you're going to be undershooting, because for the most part, for example, if someone was transplanted in July, they're only going to see half a year's worth of Medicare billings within the 2014 data set. So in general, these numbers are considered to be underestimates, if anything. There was a nice paper that was done by the Alberta Kidney Disease Network that looked at how the cost of transplant is changing over time. So this paper basically looked at two time periods. One period was 1998 to 2001. Another period was 2001 on to 2007, and just looked at how the transplant cost changed from essentially before 2000 and after 2000, if you want to look at it grossly. And these costs, again, are all adjusted to 2010 Canadian dollars. So there's no inflation that you have to consider when you're looking at these estimates. And what you can see is that in all time periods, whether it's the initial admission for transplant, the remainder of year 1, year 2, or year 3 post-transplant, the costs are increasing. and particularly in the remainder of year one. And this is thought to be due when they looked at what's driving this cost. It's almost exclusively due to the increased cost associated with immunosuppression. So whether that's treatment of rejection or actually the immunosuppression agents that we're using as standard of care, it's both. But and these numbers, again, it would be interesting to look at them now because we know that the cost of immunosuppression overall, whether you're looking at generics or when you're looking at standard immunosuppression, there has been some shift in that, particularly in the U.S., where there's a bit more of a competitive market. But in Canada, if anything, we've seen those costs actually go up. So I'd expect if we were to do this analysis again, we'd see these numbers be substantially higher. So this is work that we did to look at, again, what's an updated, more contemporary estimate of the cost of transplantation. And so this is using Medicare data, so it is U.S. data. It's third-party payer data. But we anchored this at the time of transplant. So essentially we're looking at the years of transplant after, anchored to the date of transplant and any costs that occurred before, and then while they're on the wait list, and then after, once they've received their transplant, censored at the time of graft failure. So we're not counting any costs that would include a transplant that's failed and then went on to dialysis. And what we can see is that the cost of the first year of transplant approaches $100,000, so it's higher than the previous estimates. The mean annual cost of being waitlisted on dialysis was over $80,000, and this is largely due to the fact that in the U.S., almost all Medicare patients over the age of 65 are on hemodialysis, so it's a very small peritoneal dialysis cohort. But then after the first year, we see that the cost is substantially lower, so just over $30,000. The cost does increase over time post-transplant, but that's again due to as people get older, they tend to be in hospital more, they tend to have more complications. So overall, and this is the unadjusted data, but it shows the costs are pretty high compared to what we've seen in previously published studies. This is a busy slide. I'm going to take you through it slowly. Basically, what we're seeing is the costs, the incremental costs associated with various donor and patient characteristics at various time points post-transplant. And I'll draw your attention to basically these three categories. So what we can see is that if you get a high KDPI kidney, your incremental cost so the incremental cost in the first year post-transplant is over $15,000 more, and this is likely related to the hospitalizations that they're going back and forth to the hospital. They have complications with their graft. Again, these are censored at the time of graft failure, so it does not include any dialysis costs in that. And that cost persists if they survive to their second year, so there's a higher cost in the second year, there's higher costs in the third year, and I didn't show the models that look at the fourth and fifth year, but this basically persists for the entire duration of their transplant career. The other thing that's interesting is that a history of heart failure, so this is a history of admission for heart failure in the 5 years preceding waitlisting, is a very strong predictor of increased costs, whether that's during the hospitalization, post-transplant first year, second year or third year, as is a history of diabetes. That's not surprising. Diabetics are going to certainly have more complications. We're going to see them coming into hospital more. There's going to be more physician costs associated with that. One thing I was not necessarily expecting is that somebody who's morbidly obese has a very high cost associated with it. So if we're looking at the first year post-transplant, this is, again, people BMI over 40 is our definition of morbidly obese. We're seeing a cost of $11,000 more in the first year post-transplant. And again, these costs persist as we go forward in the second and third years post-transplant. There's one caveat with this data in that because it's third-party Medicare payment data, the incremental costs associated with the initial hospitalization are probably underestimated because in the U.S. they use bundled payments to pay hospitals for their initial transplant hospitalization. So that means that whether you stay 3 days in hospital or 10 days in hospital, you're getting the same amount of money from Medicare. So there is that caveat. When we look at the impact of patient outcome on costs, this is adjusted for patient characteristics, their comorbidities, and the donor characteristics. If we look at, just for comparison, dialysis costs, so if you survive on dialysis, again, your costs are around $80,000. If you die on dialysis, the costs that are associated with that are substantial, so over $150,000 a year. And this is, again, not really due to the death itself, but it's due to the costs that are incurred as somebody is getting sicker and then dies. So ICU stays, interventions that would prolong their life. In the transplant population, we look at the first year post-transplant, again, the most expensive year. Death has a substantial impact on cost. But if their graft fails, again, this is censored at the time of graft failure, so not counting any of the dialysis costs afterwards. We put a lot of money into patients with graft failure, and this is biopsies, treatment of rejections, admissions to hospital. So it is very expensive when people have adverse outcomes on post-transplant. When we're looking at patients over the age of 65, however, most patients don't experience graft failure as their purely graft failure. They're losing their graft because of death with function. And this is, again, because of their high risk of cardiovascular disease. But most patients, if they are going to lose their graft, they're going to fall into this category of death. So I'm going to switch gears and talk about that third piece, which is the utility of transplantation. So this is still a very controversial topic. There isn't a lot of information out there, but if someone survives a transplant, how is their quality of life affected after, particularly an elderly patient? And I'll say right away, we don't have a lot of data on this. So typically we measure quality of life in what's called a QALY, so a quality adjusted life year is the most common metric. For those of you that aren't familiar with this, it gives basically an estimate of the value an individual would place on 1 year of life in a health state. So the reference is 1, which would be someone in perfect health, no medical issues, no pain, no impairment in function whatsoever. 0 would be death, and a value less than 0 would reflect a health state that is considered to be worse than death, which is rare, but there are some conditions that have a quality less than 0. The first paper that really looked at this in detail was actually a local endeavor between here and London University. Lupakis and Dr. Keon was involved in this paper as well, and several others looking at what the quality of life was pre- and post-transplant and then putting this together in a cost-effectiveness analysis. But this paper was really a seminal paper demonstrating the improvement in quality of life with transplant. They did look at a cohort of elderly patients at that time considered age greater than 60. There wasn't many, but they did show that even in this cohort there was an improvement in quality of life. So people over the age of 60 are getting a benefit from a quality of life perspective from transplant in this cohort. Interestingly, diabetics who are on dialysis had a very low quality of life pre-transplant and actually reported a higher quality of life post-transplant. And this is probably related to some bias in that their quality of life was quite poor on dialysis. And then when they're reporting their quality of life afterwards, they're comparing it to what things were like before, not necessarily comparing it to what perfect health would have been. But in any case, we see a survival benefit in all those patients, or a benefit in quality of life in all those patients. Since then, there's been over 100 studies looking at quality of life in dialysis and transplant patients, and there was a systematic review of these papers that was published in 2012. When we look at some of the contemporary analyses, the difference between quality of life on dialysis and transplant is actually narrowed substantially. So the qualities associated with a dialysis cohort using peritoneal dialysis as a reference was basically the same as what's been reported with transplant in that 1996 paper by Lupakis. So quality adjusted life years of 0.72, which is not great, but not terrible. For people on hemodialysis, the quality of life was a little bit worse, 0.69. And then for diabetics on dialysis, the quality of life was quite a bit poorer on dialysis. So you can subtract 0.11 from that. And for transplant, it was still better, but that margin of difference was substantially less. So quality of life associated with transplant was 0.82. The problem with all these analyses is that they seem to exclude elderly patients for some reason that is unknown to me. And so when this paper was trying to comment on the impact of age on quality of life expected post-transplant, they weren't able to do so. There's really only one paper that's looked at this, comparing the quality of life benefit that you'd see in elderly patients to the quality of life benefit you see in younger patients. And this is an old paper from 2003. But essentially they used something called an SF-36, which is a fairly well-accepted metric for assessing quality of life. And they looked at the various components of the SF-36 and how does the post-transplant SF-36 in an older cohort compared to that in a younger cohort. And really their comments were that we see the same expected improvement in quality of life in older recipients as younger recipients. It's a very small cohort. There's a lot of room for error, and I think one could argue that when you're looking at some of these characteristics, particularly physical function, we're seeing a substantial difference in the quality of life in elderly patients post-transplant compared to the quality of life in younger recipients. But these differences were not statistically significant because of the small cohort, so we don't really know. And then how does donor quality impact health-related quality of life? This is a busy graph, and I apologize for this, but essentially what this group did was they measured quality of life at various time points post-transplant. In the first, it was an average follow-up of 3.5 years, and they stratified it by KDPI. So this blue line you're seeing here is KDPI 0 to 20. The green line is KDPI 20 to 34. I'm not sure why they picked these cutoffs. There's a gray line in here that's 36 to 85. And then the red line is the most important one, is the KDPI greater than 85, so those more marginal kidneys. Their conclusions are a bit strong because there was only 16 patients with a KDPI over 85. So this is the only measurement we have of quality of life in KDPI over 85 kidneys, and their conclusion was that there's no difference in quality of life, which is a bit of a strong conclusion given the numbers, but also if we look particularly in the mental health components of the SF-36, there's a clear trend that it's starting to dip substantially below what we would see in other patients. But regardless, this was not statistically significant, and so their conclusions was there's no difference in deceased donor quality, or there's no impact of deceased donor quality on health-related quality of life post-transplant. So that's all the information that we have on utility or health-related quality of life post-transplant on the elderly and by donor characteristics. There is some studies that are ongoing to look at this in detail, but I'm afraid that they're going to run into the same issues, is that they're going to be underpowered to really see any difference in health-related quality of life in this cohort. So putting this all together, we'll talk about the cost effectiveness of transplant, and then we'll have some time for questions at the end. But we'll just briefly go over what is cost effectiveness. Is transplantation in the elderly still cost effective, acknowledging there's not as great a survival benefit and that the costs are substantially higher in an older cohort? And then again, how do comorbidities, advanced age, and donor quality impact the cost effectiveness of transplantation? So just as a brief overview, when we're talking about cost effectiveness, typically it's talking about what is the incremental cost for the incremental effect. And so when it's plotted on a graph, you'll often see this kind of a graph where if you have one intervention centered at the X and Y axis intersection, you can then plot the incremental cost on the y-axis compared to that intervention, and then the incremental effect on the x-axis. So things that are more effective, giving more quality-adjusted life years, are on this side, less effective on this side. If they're more expensive, they're up top, and if they're more expensive, they're on the bottom. And in general, we always see that interventions end up here, because you're never going to publish anything that shows a lower effectiveness, and for the most part any new intervention is more expensive than the previous one. The exception has been kidney transplant because it's been cheaper and it's been associated with a survival benefit. So it's one of the few interventions that end up in this bottom quadrant, which is improved effectiveness at lower cost compared to the standard therapy. But does that still play out in elderly patients? So if we go back to that first paper that talked about the cost effectiveness of kidney transplantation by Loupakis, they did describe that there was cost savings with transplantation, improved quality of life, and improved survival at lower cost. But they didn't calculate the expected cost per quality adjusted life year in an elderly cohort, even though they had the survival data and they had the utility data. So whether that just didn't make it into the final publication or not is unclear. And again, they had a fairly small cohort. So, and their cohort of elderly patients was fairly small. It's less than 50 patients, I believe. And their time horizon for their calculations, they only looked at the first 2 years. They didn't look at the long-term expected cost and survival post-transplant. But it was a start. This is the most recent contemporary cost-effectiveness analysis we have. This is from the U.S. data that was published just this past year. And I'm not sure how this got through this. They missed a decimal point. This should be kind of $850,000, not $85,000. They looked at a 10-year time horizon in their cost-effectiveness analysis. The costs are plotted on the y-axis. The effectiveness is plotted on the x-axis. And you can see that dialysis is this yellow dot here, that over 10 years, it's between $700,000 and $750,000 expected cost per patient. If you compare that to living donor transplant, which they divided these up by mismatches, are down here. And so, again, we're seeing a substantial survival benefit at lower cost. But this, again, is just a general cohort. They didn't actually look at what the impact of age was. They did look at donor quality. So the KDPI greater than 85 group, this is, again, the more marginal kidneys, is this blue dot here. And you can see that there is still an improved survival with lower cost in this cost-effectiveness analysis. The other categories are things that we don't necessarily do very often. So, for example, ABO incompatible transplants and incompatible living donor transplants are not something we routinely do at our centers. This is work that was done at the University of Toronto, looking at the cost effectiveness of transplantation in the elderly. This is the only previously published cost effectiveness analysis of transplantation in the elderly, looking specifically at outcomes and the impact of comorbidities on the cost effectiveness of transplant in the elderly. What they found was that it's no longer cost savings in this population. So in a group over the age of 65, they found that there's actually substantial costs associated with transplantation in the elderly, and it's not cost savings compared to dialysis. And if you look at a diabetic with cardiovascular disease who's going to be waiting 2 years on dialysis for a transplant before they get a transplant, the incremental cost of waitlisting that patient for an additional quality adjusted life year was $200,000, which is well above what we would consider cost effective. The problem with this analysis in today's setting is that they're using very high risks for bad outcomes post-transplant. So their risk that they assigned for risk of acute rejection in the first year post-transplant was 40%. So this is data that's essentially based on data between 1995 and 1998. So that may have been accurate at that point in time, but certainly is an overestimate for complications post-transplant that we would see now. The other thing is that it's not necessarily fair to consider waitlisting to not waitlisting as your metric, because if you're looking at your overall dialysis cohort, which they did, you're not going to be waitlisting everybody. You're going to be waitlisting a select set of individuals. But then if we look at this model at the bottom, which is comparing a donor with no wait, basically this is that decision point of you get a transplant today or you stay on dialysis, there was still cost associated with that. So I'm not sure how to interpret this analysis in today's setting. I think it's interesting. It's the only one that's been done in the elderly, but it certainly is maybe not applicable in today's setting. So we redid this looking at groups of elderly, so age 65 to 69, 70 to 75, and greater than 75, and looked at the cost effectiveness of this. And if we look at the cumulative cost, this is over the lifetime of a patient. If they're going to remain on dialysis, the cumulative estimated cost was between $38,000 and $400,000. And their expected survival, this is in quality adjusted life years, so again, using that 0.72 quality adjusted life years is what you get out of 1 year on dialysis. We're looking at just over 2.5 quality adjusted life years if they remain on dialysis. So in this cohort, 65 to 69-year-old group with your standard comorbidity burden within that cohort, you see whether, regardless of what kind of kidney you get, you see that this is a cost-effective therapy. And obviously, living donors get the best bang for your buck. So you're getting the most survival, and over time, your costs are very similar to other forms of transplant. Now, if we look at the 75-year-olds and older, the story is a bit different. So we still see that it's cheaper with transplant. They still get a survival benefit. But the incremental cost savings that you get is really very small. So we're not seeing that big cost savings that we see with the younger cohort. And then if we overlay multiple comorbidities, so this is simulating a cohort over the age of 75 who has diabetes and heart disease, we see that there is still a survival benefit, but this is, again, driven because outcomes on dialysis are quite poor. We're only expecting to see 1.5 years of quality-adjusted life years on dialysis in this cohort. And with a living donor, you do see a substantial improvement, but it's no longer cost savings to be a transplant recipient with age over 75 with multiple comorbidities. And if you look at the improvement in expected quality-adjusted life years with a lower quality kidney, you're only getting one additional quality-adjusted life year and not saving any money. Now, if you calculate the incremental cost-effectiveness ratio, which is often done, these are all in the range of 20 to 30,000, which is still considered a cost-effective therapy. But I think when we're talking about a scarce resource, we have to consider that perhaps that's not what we should be looking at as our outcome of interest, not looking at incremental cost-effectiveness, but where, when we're allocating kidneys, how do we allocate them in a way that we're maximizing the benefit of our population? This is just looking at, so there's uncertainty in all these measures, so we did what's called a probabilistic analysis, where you run essentially the analysis through thousands of times with changing each variable slightly each time. And the results are fairly consistent. So this is not just a function of the data, essentially. So the conclusion is kidney transplant in the elderly does improve patient survival in selected individuals. It still costs savings compared to hemodialysis in most elderly patients. But in patients with multiple medical morbidities, particularly that advanced age, it's no longer cost savings. So this is my final slide, and then we'll go on to some questions. But just in terms of looking at this in a bit more of a broad picture. So we've talked a lot about just the cost compared to dialysis and the survival compared to dialysis. What hasn't really been talked about is something called allocative efficiency, which is making sure that we have a pool of kidneys that we're using to benefit the society as a whole to a maximum. And this is a tricky thing because when you talk about people on dialysis, you can make the argument that everyone on dialysis is equally deserving of a kidney transplant. That's not a perfect argument, but it can be made. And that's kind of how we treat our wait list, in that if you're eligible for a transplant, then you go on the wait list, and your spot is the same as somebody who's been waiting the same amount of time on dialysis as you. We do some differences in how we allocate the kidneys, in that younger kidneys go to younger recipients, older kidneys go to older recipients. But I think that when we're talking about older patients, particularly with comorbid illnesses, we do have to think about the allocative efficiency of how we're distributing these kidneys, in that it may not be in the patient's best interest or in society's best interest to waitlist them, and that decision has to be made very carefully. And I mean, we're not going to be excluding somebody just on the basis of their age, but I think we have to consider that in a little bit more detail. And when we're talking about the choices of society, we really have to think, what would society rather us be doing with a very, very scarce resource such as kidney transplant? So that's just some food for thought. There are still some unanswered questions, particularly we don't have Canadian data on this, which I'd very much like to get. And the quality of life post-transplant in the elderly is very poorly understood. I'd like to thank the CIP and the AST Research Network for their financial support, and then obviously many thanks to my supervisors, Jag and John, and Dr. Clarenbach at U of A for their mentorship and guidance through this work. And thanks for your attention, and I'd like to take questions if you have any.
Yeah. I have to ask one question.
Yeah.
I just have a question about the use of American data.
Yeah.
And a few years ago, when I was looking at the transplant cost-effectiveness literature and its implications in the cost of glomerular disease treatments, because the treatments are quite the same. And I was surprised to find out that the Medicare-Medicaid program stops covering immunosuppression after a certain period of time. Except, of course, if patients are over 65, then they're covered under Medicare in the United States. So when you're using American data to look at cost over time based on age, how does one account for, if you're looking at the longer time horizon using their own data, that the elderly patients are going to have obligatory drug coverage over a longer period of time, whereas at least a few years ago when I looked, there was a policy of not covering immunosuppression and offloading that to either individuals or other private payers. Now, I don't know if that policy has changed or how you accounted for that in your use of American data for costs.
Well, for my data, it was very convenient because my sample was age greater than 65. So they're all covered under Medicare, and therefore those immunosuppression charges go to Medicare, and I have that incorporated into the third-party payer data. Now, for the age greater than 65, which wasn't part of something I looked at, but every other analysis looks at, they basically take what would be the year 2 data, and then they kind of roll that over, and that would be the cost of immunosuppression going forward. But yeah, it is still the policy in the U.S. to discontinue immunosuppression coverage after 3 years post-transplant and age under 65, unless there's another indication for Medicare coverage, which would be disability. But that policy is it's actually under review under Congress right now, so they're looking at extending that to lifetime immunosuppression coverage. But the interesting thing is that they're not going to be extending Medicare coverage. It's just the immunosuppression coverage, so not looking at the other costs that are actually much more substantial than the immunosuppression. So in the U.S., the cost of immunosuppression has gone down substantially. It's a competitive market. They have generic immunosuppression competing with our brand name immunosuppression, and that's driven the cost of both the generics and the brand names down. In Canada, we don't really have a competitive drug market, so that really hasn't been seen here. But if you look at the cost of immunosuppression for a year of TAC and a year of MMF in the U.S. now, if you're using brand, it's actually only $2,000 for TAC and $2,000 for MMF a year if you're looking at that more than 3 years post-transplant cohort. So it's not a substantial cost compared to the other costs that are associated with kidney transplant. But that's a good question. Sunit?
Yeah, hi, but like in all areas of nephrology, we sometimes don't know what the best outcome to measure is. So I'm going to leave mortality aside because mortality is like universally accepted as the best measure, but I'm not sure that it's the most valid measure in someone who's 75 years old. So if we just look at quality of life, and fortunately I've made it through my life so far without really analyzing the SF-36, but certain factors are more important to the elderly than they are to the young, right? So we're using a single measure, even though certain factors have more weight in one group than the other. So if people dig down a bit more deeper into what aspects of their quality of life are improved or not improved, so for example, if it's just I don't have to travel to dialysis, but I'm completely disabled sitting at home all day, but that's still better than being disabled and traveling to dialysis. Is that a decent measure, or what measure do you think we should be using? Should we be doing a different quality of life or being a bit more specific about single factors?
Yeah, I think that's a good question. I don't have a great answer for that. The SF-36 is a convenient way of measuring quality of life, and I'll say that it's convenient, but it's not the best. So we know in a younger cohort, if we look at some of the standards, the standard is something called a standard gamble, which is basically you offer patients a choice. Would you take this gamble of dying, 20% chance of dying, or would you rather just stay where you're at in your current state of health for another year? And so they offer patients various options, and that the idea is that through offering them these various options, you can determine kind of where they place a value on their current health state. And that's the standard way of determining quality adjusted life years. The SF-36 is not actually validated to a standard gamble, and in kidney patients, it actually routinely underestimates quality of life. So I don't think it's a great measure. It is a measure. And when we're looking at all of these studies, the biggest issue has been the numbers. So trying to get numbers into these studies to understand what the quality of life is. And if you're going to be going through something like a standard gamble, which is very expensive, very hard to administer, is it worth it to go for the gold standard, or is it better to use a measure that we can administer fairly easily to a larger group? It's a hard question. I don't know what the answer is. The nice thing about the standard gamble is that it wouldn't matter what component of your health is affecting you the most. It just matters the value you're putting on your current health state. So it would be nice to do that in a large group of elderly patients post-transplant and really get to understand that. But that would be a very expensive study to do. So I agree with all your thoughts in that, what we're measuring in the SF-36 may not be what's actually important to an elderly patient. But I don't have a solution to that. Great question, though. Any other questions at any of the distributed sites or St. Paul's? Any questions? Oh.
Comment that there's recent publications in terms of precision medicine and customizing immunosuppression for the elderly in a different way. And some of the complications and bad outcomes, one could argue, are because of a one-size-fits-all, which is all the old data. And could you model different outcomes based on changes in complication rates? Because I think that part of all of this is informed by the complication rate and the lack of perfect function. And if those things change.
Yeah. I think it would be nice if we could model, what would the scenario be like if we use perhaps less immunosuppression, and how would that affect the outcomes? The biggest problem with that is that whenever you're looking at smaller subgroups and more precision medicine, is that you're getting more uncertainty around your estimates. And so unless we have fairly rigorous data to inform those analyses, it becomes very tricky to make any kind of assumptions. So as much as it would be nice to be able to model that, I think that it's very challenging. Now, inherently, we do modify our immunosuppression already in the elderly, whether it's subconscious or consciously, and some of that is because we know that elderly patients are already immunosuppressed on dialysis, that they don't have the same thymus function as a young 18-year-old. So we're not giving them the same doses all the time. But again, if you go into it, and we're often left with applying kind of a cookie-cutter approach to our transplant patients, we don't have good markers of what their immune function is going into transplant. And so we often kind of start off with this one-size-fits-all, and then we see BK viremia and CMV viremia and numerous infection complications, and then we're forced to dial back their immunosuppression. So they end up with a customized regimen on the basis of encountering a lot of complications along the way. So it's a good question. Any other questions before we finish off the session? Okay. Thank you very much. I appreciate your attention. Yes. We don't have it for transplant, though, because we don't pay for everything.